Her research focuses on defining best practices in culturally competent care and disseminating those findings. She has served on the Health Partners Equitable Care Sponsor and Oversight Groups since their inception and helped lead the subgroup that defined Health Partners demographic data collection, which is critical to reducing health disparities. She will be speaking to us today about displaced persons and the diseases that follow. Dr. Walker.
Good morning. Thank you very much for staying today. Thank you for the introduction and the opportunity to speak on displaced persons and the diseases which follow. We are experiencing the largest number of displaced persons in history, resulting in unspeakable tragedy on a personal level for women, children, men, and their families, and of course, tremendous repercussions for political and social discourse, financial strain on individuals, on governments, on international organizations, and health concerns for both individual refugees and the public health of first asylum and resettlement countries. For us, as individual practicing physicians, this phenomenon of rapid global migration means we have to stop thinking about diseases here and diseases over there, that we must acknowledge that there is no such thing and that we must prepare the next generation for their capacity for handling tropical infectious diseases. I'll actually be focused on those as it relates to displaced persons today, but also will acknowledge and really appreciated the comments from Dr. Semenza about the fact that the current migration has very little in the way of tropical infectious diseases and more chronic disease. Although this is not a new phenomenon, European immigrants brought TB to the United States 100 years ago. It's a larger issue both because of global population growth and the numbers of people migrating around the globe and the speed of that travel, obviously. Amazingly, just a couple of numbers, more than 1 billion people fit the WHO definition of being an international migrant. I think those of us who are speaking today are probably all fit that definition. I was born in Taiwan and now live in the United States. They've lived outside their country of birth for more than 1 year. So how many of you are migrants by that definition? A lot of people in the audience. 1.2 billion tourists traveled worldwide and 68 million Americans traveled abroad in 2014. So today I'm going to focus on how the U.S. addresses both internationally and domestically the health concerns of the displaced. And I also have no conflicts of interest, although I haven't voted yet. So I will outline for you briefly some demographics about displaced persons. I think it's really important to look briefly, a couple of minutes, on the history of refugee protection. Being a clinician, I'm going to use a case study that will highlight the U.S. international and domestic refugee response. And throughout that, a few months ago, I was asked to imagine our future in refugee health. And so I'm going to sprinkle in a couple of comments about that. As mentioned, we're experiencing the highest level of human displacement in history, 65 million displaced people internationally. 21 million of those are refugees. Half of those refugees are children under 18 years old. 34,000 people every day are displaced worldwide. 54% of refugees worldwide come from 3 countries, from Somalia, Afghanistan, and Syria. In fact, for 3 decades, Afghanistan had the most refugees worldwide, and Syria took over that dubious lead 2 years ago. Where are the world's displaced people being hosted? Primarily now in the Middle East and North Africa, 39%, 29% in Africa, with the top hosting countries being Turkey at 2.5 million, Pakistan, Lebanon, and other countries. The Syrian refugee crisis, since the civil war began in March of 2011, 6.6 million people have been internally displaced. 4.8 million have fled to Turkey, Lebanon, Jordan, Egypt, and Iraq. More than 1 million have requested asylum in Europe. Just a brief history lesson. The modern refugee protection movement is actually less than 100 years old. I began as a third-year medical student working on the Thai-Cambodian border in 1979, And I knew very little about refugees and refugee protection at that time, and that the refugee protection movement already was 58 years old at the time. Certainly when you think about protecting refugees, that has occurred since antiquity. International protection began formally with the League of Nations in 1921. And the Convention on the International Status of Refugees occurred in 1933. That was the first time the